So we'll go ahead and get started, and Katie Shakoyan is going to start us off today. Thanks for engaging us in that cool activity. Both are very important.
Yes, and thank you, Nicole. Well, welcome everyone. You're here for the first of our Meth Use in Focus series. This is on leveraging quantitative data for effective prevention. And you can go to the next slide, Nicole. So we at the South Southwest Prevention Technology Transfer Center, the PTTC, are under a cooperative agreement with SAMHSA and with CSAP, the Center for Substance Abuse Prevention. So the opinions expressed herein are the views of the authors and don't reflect the official positions of the Department of Health and Human Services or SAMHSA. We can keep going from there. So as we mentioned, this is the first of a three-part series. So today we're going to be talking really about quantitative data for effective prevention around meth use. If you come back next month, we're going to have a separate webinar specifically around available qualitative data and how to collect your own qualitative data. And then we're going to be releasing a data brief with our findings on meth use in the South Southwest. And we'll have a lunch and learn to release that to you all in September. We can keep going. So the objectives for this morning are to define the key quantitative trends in meth use for the region, as well as to identify gaps in available quantitative data that hinder a comprehensive understanding of meth use prevalence. And to do that, we're going to start with some introductions, just as we're doing right now. I'm going to pass it over to Nicole in a second, and she's going to share some background of methamphetamine use. And then we're going to talk about meth use and meth mortality as sort of two different indicators of what's going on in the region. Then we'll look at what's missing. Where are the gaps in the quantitative data? We'll have some time for questions and answers. And of course, as data folks, we really value your feedback through our evaluation of this project. We can keep going. So here's our data team at the South Southwest PTTC. It consists of Nicole, our evaluator, myself, our epidemiologist, and Sheila Boswell, who's also on with us today, who is our evaluation and design coordinator. And I'm going to pass you to Nicole, who is our fearless leader today. Nicole brings 20 years of award-winning public health experience to the South Southwest Prevention Technology Transfer Center. She currently oversees all evaluation reporting and analysis and manages the evaluation database for the South Southwest PTTC. She plays a vital role in providing high-impact training and technical assistance services to the prevention workforce, emerging prevention professionals, organizations, and community prevention stakeholders. Nicole also is an internationally certified prevention specialist and an adverse childhood experiences interface certified instructor. And we are so excited to hear from you, Nicole. I'll turn it over to you.
Sure. Thank you, Katie. I just have to say that I would not be here without the team that you see here on the screen, as well as Wanda and Richard, who help out with all of our webinars and instructional design and tech. So just want to give a shout out to them before we start, because without all of their expertise, I would not be able to do this today. So thank you all. So I'm so glad to see all of you here. I really am excited about what we're going to talk about today. We have some major issues with meth use and as well as meth mortality going on in our region and nationally. And things have changed, right, since the past. We've had some policy changes with meth use that have affected some of the use and mortality and making it look a little different than it has in the past, but there's still some things that are similar. So we're going to get into all of those things. We're going to go over a lot of data, but we want you to engage with us. We're going to have some breakout rooms and make this very interactive. So during those times, even though we've got a large group, I encourage you to unmute in your breakout rooms and be able to have a more intimate conversation about what you're seeing in your local communities. So with that, we'll get started here. So The background of meth, it's a highly addictive stimulant. It's used via smoking, snorting injection or ingestion. There's some short-term euphoria, long-term health and social harms. So we have seen some unprecedented increases in methamphetamine-related mortality over the last decade, especially. Methamphetamine has the high potential to become addictive. It enters the brain quickly and really provides folks with a very large, what I call dopamine dump. And so, with that, we're up against a lot as prevention professionals because there is a very high euphoria that comes with that. It's very reinforcing, leads individuals to want to take the drug repeatedly. And in recent years, nearly 2 out of 3 people aged 26 and older who reported past year meth use met the criteria for a substance use disorder. So let me say that again. 2 out of 3 people aged 26 and older who reported past year meth use met the criteria for a substance use disorder. That's very high. So now we're going to do a little activity, and I just want to know from you all, and you can raise your hand since we're in this large group here, how many of you are already collecting data on meth use in your community? Just raise your hands. You can raise it electronically, or you can raise it like me because I'm low tech. Either way is good. All right, seeing a lot of hands. That's great. That's great. And if you haven't started, this is a great place to be today. So, the next question we have for you, and Richard has posted that in the chat, is if you are collecting it, what sources of information are you using? So if you can just type those in the chat, we'd love to hear from you. And we'll be talking about a couple major national ones today, but maybe you all are using some state level data, treatment data. Yes, treatment data can give you an indication as to what's going on, maybe even with use as well as mortality. NISDA a bit. Hi, Susan. Good to see you. Some local, but that's very spotty. Law enforcement hospitals, great. Susie says student surveys, overdose data. So lots of state surveys. States are a great resource for that. And sometimes with the national sets that we're going to talk about, you may not be able to look at the county level as much. And so going to your state resources is a good way to deal with that. John says the Oklahoma Prevention Needs Assessment. That's been around a long time. Great source of information there. Great. Chief Medical Examiner. Yes. Yes. Looking at those death certificates, right, from the medical examiner offices. Those are great sources of information. Okay, and we've got hospitals, fire departments, and surveys. All right, well, you all are have listed some great local resources as well. And so make sure you're getting with your communities and your states to get some more of that. All right. Thank you all for participating. So with our sort of examination, and today I'm going to talk about you all being data explorers. We've been data. So getting intimate with the data is always where you have to start. And so we today are using the national sources of NISDA, which is the National Survey, and we included the link there for you all, as well as CDC Wonder. Wonder is a great resource for mortality data, whereas NISDA is a great resource for use data. And we're going to talk about both today. We do have, before we go on, we do have more customized ways of working with Wonder. And so if you do need more intensive TA on the actual codes to use to run some of these things, let us know and we can work with you to do that because there's a lot of disease codes and it can be really frustrating to work with Wonder at first. So if you need help with that, please let us know. All right, so first we're going to talk about methamphetamine use data. And this is going to be from NISDA. All right. So this is just an overall look at what's going on nationally. We see that in our region, the maps show higher state use prevalence in New Mexico, Oklahoma, and Louisiana, which you see are in the darker color there. That means there's more data there. And we also have several states with some of the highest prevalence of meth use. So, and again, this is focusing on use, but we do have a very high rates in New Mexico, Oklahoma, Louisiana. You can see that Texas does not look as dark, and so we don't see as many cases there. However, we do see some in Arkansas as well. So, any questions there? But that's kind of a broad overview of the US. Okay, Troy says, I can attest to that being an EMT in the emergency room. We would see a lot of methamphetamine overdoses. Yes, and we will be talking about mortality as well later. Thank you, Troy. All right, so I think that one of the things we have to look at as data explorers is, what are some other sources of data that may paint a picture, right? And we'll be talking about this throughout the day. So some of the newer trends in meth point to less of the homegrown meth that we see, some of those that has resulted from policies, controlling pseudoephedrine, et cetera. And now we're seeing more transport of meth. And so Region 6 is home to some of the major interstate highway corridors and methamphetamine seizures in 2024. And we have I-10 and I-40 that have some of the highest amounts seized in the country, which you can see run right through our region. I should highlight that our region includes Texas, Louisiana, Oklahoma, Arkansas, and New Mexico. But if you live in another state and you're joining today, there's a lot of information there as well for some of the other regions, including what you see over in California and Georgia. So we do not see as much meth in kilograms seized on I-35, which runs, north and south. While Texas does have high meth use rates, or does not have high meth use rates, I'm sorry, we do see high seizure amounts. And so that's an interesting issue because if you look at the map prior, we didn't see a lot of use in Texas compared to some of the other states, but the transport levels are high and the amount seized. So at the same time, we see lower seizure amounts of meth in New Mexico, right? But in our prior map, we saw a lot of use in New Mexico. So it has some of the highest use rates in our region, but not as much transport or not as much kilograms seized. So how is meth getting there, right? So these are some of the questions that we start to think about as we're looking at the data. Let me just check the chat here and make sure I'm not missing anything. Thank you, Katie. Yes, I wonder how much that has changed in 2025. Yes, we definitely wonder that too, and we'll be seeing what the new data shows. So our meth trends rundown. We have seen unprecedented increases in methamphetamine related mortality that have occurred over the last decade. From 1999 to 2021, there was a 50-fold increase in methamphetamine mortality rate nationally, which was accompanied by an increasing proportion of deaths that co-involved heroin or fentanyl. Adult meth use rates in our region are currently significantly higher than the national average and use rates in Arkansas, New Mexico, and Texas. How can we best understand these alarming statistics and what can we do to prevent future meth use and mortality? So some of the things we need to look at are those key trafficking routes, I-10, I-20, I-40, the high use in rural and tribal populations in our region, and meth-related overdoses and treatment admissions that we also see are increasing at the same time. And I know Troy was mentioning some of that. So anyway, it does paint a little bit of a bleak picture, but as prevention professionals, we do know that we have ways to address some of these issues, and we are addressing some of them. So this is a nice chart that just kind of provides the overview of things in our region. So we are seeing in the US population a 1% use rate for the total US. But when you compare to our region, you see that every state in our region is above the national average there, except Texas. So Texas is hovering more around the national rate, while all of our other states are above. And so this means that we have some work to do, right, in our region. They represent also a significant increase from even 5 years ago, although we do have some issues comparing from prior years with NISDA data, because the methodology was changed a little bit. And so we can't make a direct comparison, but we can say we do see some patterns that seem to be emerging and increasing. So now let's talk to you about what you're seeing. We're going to do some breakout rooms, and Richard's going to get us into those here in a minute. But what we would like to see you do is just do some quick introductions in your group. And then if you would like to, if someone wants to volunteer to be the facilitator for the two questions here, and then maybe someone takes more extensive notes, we will probably hear from one group as a report out when we come back, just because we have such a large audience today. But um, any questions about that before we move into those breakout rooms? All right. I don't see any. Richard, I think we are ready to go to the breakout rooms. All right, everyone. I can see faces coming back from the breakout rooms. Good to see you all again. I hope you had a good discussion. And I know that these questions, when we get at the local level, there's a lot of nuances that are going on too. And so I'm sure you had some really rich conversations. So would any of the groups, we'll probably take one just in the interest of time, but is there a group that would like to share with the large group what your responses were and some of the discussions you had? And you can come off mute and turn on your camera if you like.
I'll go.
Thank you, Anna.
I work in the Department of Corrections at Guadalupe County in New Mexico.
Mhm.
It's a medium security men's facility. And what I'm seeing as far as the data and how it connects with what we see in the prison community is that the big cities are having some real big, it's an epidemic. And it leads to homelessness, criminology, and to our facility. And so in rural communities, there's such a shortage in prevention, I mean, treatment and early intervention that very seldom is it caught on time to keep them from being part of our prison statistics. So that's what I have as far as that goes.
Yeah.
And how has meth impacted prevention? Well, because the signs are so visible as far as the decompensation physically and mentally with long-term use, I think that serves to prevent people that are aware and are looking, and it's reinforcing that just say no kind of concept. But unfortunately, we also have multi-generational meth use. And with limited access to treatment, it's hard to disrupt um, that chain.
Mm-hmm. Mm-hmm. No, those are all very, very good points. Meth can be really devastating, and with the increases and the connection to criminology and things like that, it there's a lot that goes into helping someone manage that, and we don't have the treatment that we have for opioid use disorder, and so all of those things, rurality, not having access to healthcare, all of those things go into those drivers. Very good points. We might have time for one more person if another group would like to share real quick. And if not, that's okay. All right. Well, hearing none, let's go ahead and move on. I'm really glad that you all had those conversations, and it just highlights how those things can impact things at the local level. So now we're going to talk about mortality rates and what we are using as a data source for this is CDC Wonder. And there's ways you can put in codes, disease codes to get at the meth related overdose issues and mortality issues. So that is what we will cover. And we're going to break this down by each state also. So I'm excited to show you these maps. And I think that it will really highlight how we have seen the increases happen and the different nuances that occur in each of our states, along with mortality rates. What we will be using is the crude death rate. There are some different statistical ways to control for age, like age adjusted mortality, but here we will be using the crude death rates, and we did look at the data, and there were not significant differences between using those two methods. So we're going to stick with the crude death rates. I just wanted to make that note for you eppies out there. So here is a comparison of all of our states in the region. And so you can see the dotted line is the US trend line over time. And then you can see how, yes, Texas and Arkansas in 2023 are below our US trend line. However, Louisiana, Oklahoma, and New Mexico are all above. And there's some interesting patterns in the data. We do see around 2018 and 2019, we start seeing these kind of significant increases in the mortality rates. And then New Mexico had a very big spike around the 2020, 2021 area. Then you can also see that some trends look like they might be starting to go down a little bit, like in Louisiana and then Arkansas. But then others like Texas, we're starting to see this sort of increase, even though overall their mortality rates had been lower than the US average. But that could also indicate that there's something starting to happen. And so that's why it's important to look at this from a very big sky kind of view, like what's happening in the states around us? How does that compare to the US? And are we starting to see some decreases, even though we have overall high rates, like in New Mexico? So, according to CDC, in 1999, the crude mortality rate per 100,000 in Region 6 was around 0.2, and that's for the region on average. But by 2023, it had jumped to 11.1. So, that is a huge increase in the rate going from 0.2 to 11.1 in 2023. So now we're going to do a poll, and Richard's going to bring that up. And go ahead and answer this. What trends in methamphetamine mortality rates are you seeing in your communities? I know this is big sky view here on the map, but what are you seeing in your communities? Now you guys are answering great. I love the participation. We are almost up to 70%. We'll give it just a little bit more time. All right. So, Richard, let's go ahead and end the poll and let's see what our results are. All right. So, we are seeing the largest, not sure. right? So, and I think that really sheds the light on we have data nationally, we have data at the state level, but it's much harder to get that community level data to see what's going on right in your own area. Um, Other than that, though, the largest response was an increase in meth overdose. Yep. Stayed the same was 10%, and the decrease was 6%. So not a whole lot of people saying we've got a decrease, right? Mostly we're saying we're not sure, and we are also seeing an increase. So that's great. It's great. I mean, not great that we're seeing an increase, but great that you all are taking a look at the data and know that you have these things going on. So. All right. Thanks, Richard. We can go ahead and close out that poll. So now that we've seen the data with comparisons for our region, we're going to take a little look at each of our states. And this was a way, and I have to give credit here to Katie, who thought, you know what? We've got a lot of data suppression because, we don't have CDC Wonder will suppress data if it's unreliable or there aren't enough data points. And so we took an average of 2016 to 2019 crude death rates and compared that to 2020 through 2023. And so what you'll start to see is that even with keeping the scale the same, you're seeing this huge sort of spread start to happen in those year changes. And so while we had a few in Arkansas in 2016 to 2019 cases showing up, some, larger than others in the center there. But then when you look at the recent gap in years there, you're seeing much more spread, higher rates, additional counties showing up. And so this really illustrates that we do have something going on. And this is Arkansas, which has some of our lower rates in our region, but you can still see when you break this down with the data that things are moving towards spreading in other counties. So let's take a look at our next state in Louisiana. We see, a few showing up here and there in 2016 to 2019. We have one parish that is a little bit darker there, showing more cases of and more crude death rates per 100,000. But then we move into 2020 to 2023, and wow, look at that increase. I mean, that definitely goes along with what we were seeing in the jump in the chart previously where we were doing comparisons, but at the parish level here, we can really see the disbursement and how this is spreading. Let's move to New Mexico. New Mexico has some of our highest rates overall. But when you break it down at the county level, you can also see, okay, where are the hot spots? Where are things happening? We started out with a majority of the crude death rates being higher in sort of that upper corner and the lower corner there. But now in 2020 to 2023, we're seeing that spread to more counties with a county that didn't really show up in the initial date range map, but in the more recent date range map, 2020 to 2023, showing up in a big way. So, and you can look at the bottom scale for the crude death rate there at the bottom of the map. And that's going to show you that it goes up to 52.4. So a very, very high number of deaths happening in that county. Oklahoma, my home state. So Oklahoma also had a lot of counties that were showing up in 2016 to 2019, not looking, you know, super on the high range. However, we moved to 2020 to 2023, and all of a sudden we have a lot more counties showing up in those darker colors that indicate a higher mortality rate. And Oklahoma's overall numbers are higher too. So, up near that 37 crude death rate range. And finally, Texas. Texas has a lower crude death rate overall than our other states in the region, as well as below the national average. However, what we are seeing when we break this down, and that's why this is so important to do at the state level and local level, we are starting to see things increase in certain counties and additional counties showing up with higher death rates. So that can indicate that we need to intervene. We need to, put programs into place, even though our overall crude death rate is not as high as the other states in the region.
Nicole, we do have two comments in the chat.
Oh,
One
sure.
question and one comment that I think would be worth looking at.
Yeah.
Would it be helpful for me to read them to you?
Yes, I
Okay.
see a couple, but yeah, if you could
So,
go ahead and highlight them.
yeah, so Karen is asking, do we have any meth recovery data sources that you know of?
Meth recovery data sources. We didn't focus on that in this presentation, but I'd be more than happy to get you some, Karen.
And
Okay, we will
then
follow up with that.
a question from Troy is around 2020. I know in Las Cruces, New Mexico, we also saw an increase in homelessness, and we don't know if other states were the same. I think there's something there too.
Good point. I think we did not do this in this presentation, but I do think that would be interesting to overlay, mapping data between meth death rates, as well as homelessness, and look at some of those other health drivers that we see, that we experience in prevention. So good point, Troy. Any more questions, Katie?
I think those are what we've got in the chat so far. A few things have come up that got answered there as well.
Thank you. And thank you all for being so interested in this. I can tell you're thinking deeply about the connections, and that's awesome. All right. Well, we have another small group discussion, but before we get to that, we'd like to do another poll. And so Richard is going to pull that up for us, and it's around local data sets. So, what are you seeing in the local data sets you are reviewing? And which statement best describes meth overdose in your area based on those local data sets? Well, this one digs a little deeper than our other question, focusing on those local data sets. Okay, we've got about half of you participating. Oh, it's jumping up. We are really getting a lot of great participation today, Katie. Okay, Richard, I think we can close the poll. We've got about 3/4 participating now. All right, so most of you said it's a growing concern, but not widely talked about. Well, I'm glad we're here today then. Good. I mean, good that you all are here and you're interested and want to do something about this. We've seen a clear increase in meth-related overdoses, came in at the next biggest response. And then, or actually, no, not sure, need more information. So we've got a growing concern, but not widely talked about. And then second is we're not sure, we need more information. So it does sound like it's a great thing that you all are here today, getting more information. Some of you definitely know that you've seen a clear increase. And then some of you say it doesn't seem to be a major issue in our community. Yeah. And sometimes that's the case, right? With if you live in a rural area, I'm from a rural area myself, that a lot of these things aren't talked about due to confidentiality and other things. And if services aren't available in those areas, then we may not know as much that people are suffering with something. And so I think those are all really good points. All right. Thanks, Richard. We can go ahead and close that up. And then we will move into talking in our groups now with a little bit more intimate conversation. And Richard, I think we'll post there we are. Those are our questions for our polls. So are there specific state or local data systems you turn to when you're tracking overdose? What are their strengths or limitations? And then what changes or trends related to meth overdoses have you observed in your community over the past year? And this is specifically focusing on mortality and overdoses, unlike our other question on use. So we will go ahead and break all of you up back into your small groups, and I'm going to do a time check here. We have time to do 10 minutes again in our group discussion, and then we will have a report out from one of you. So looking forward to hearing your conversations. So now that we have everybody back, is there a fearless volunteer who would like to offer some of the things that they talked about in their group? No pressure.
I will.
Thanks, Emily.
Yeah, I popped into my group a little late, but the conversation we were kind of having when the groups closed was about the qualities of provider-based stimulants or provider prescribed stimulants, your Adderall, that kind of a medication,
Mm-hmm.
and illicit substances or substances that are not prescribed or controlled through a pharmacy, and that the step between using one or the other can be huge progress, even if it's not fully abstinence. From a harm reduction perspective,
Mm-hmm.
the chances of getting an illicit substance that is combined with a more harmful agent, your xylazines, nitazines, that kind of thing,
Mm-hmm.
it decreases significantly if you're accessing your Adderall through a pharmacy.
Mm-hmm.
So it's, just kind of being conscious of folks who are in recovery, making steps along the way, even if their next step isn't full sobriety.
Right.
It's still going to reduce their overdose risk to have a controlled substance in a prescribed manner available to them consistently.
Mm-hmm. Mm-hmm. Thanks for bringing that up. Sort of like, using methadone, right? In that instance. Um, and there are some important new areas of research coming out, and we will, in part three, when we talk about the data brief as a whole, we will be talking a bit more about some new on the horizon things that might be coming, as well as some evidence-based practices that can address this. And while we don't have, naloxone and some of those things we have for opioids, there are some things that we can do. So thanks for bringing that up. Anybody else like to share real quick? Or you can post your response in the chat as well. Looks like Dr. Leslie has come off mute. I don't know if you were wanting to share.
I'm sorry. I don't want to share.
Okay,
No,
that's all
I
right.
apologize.
That's totally fine. I just wanted to make sure we didn't miss anything. So
Thank you. Sorry.
you're welcome. All right. Well, and if you would like to share some more of your discussions, I saw that Mackenzie did that earlier and put some of their discussions in the chat. So with it being such a large audience, feel free to do that so that we can hear what you talked about. So, oh, and Kendra said we did discuss many communities lack tracking. Yes. Yeah. It's sometimes a data issue, right? And looking at some of those early detectors, some of those early warning systems for data tracking may help us improve some of that. So that is an area that, even in terms of epi, we can learn to expand so that we can monitor disease trends more quickly. Thanks for bringing that up. All right. Well, thank you all again. You have been an awesome participatory group, especially given the size. So I really appreciate all your feedback today. So now we're going to talk about how do we address some of the gaps we see in the data. We've talked about, okay, well, we're not able to track very quickly, or lack of tracking at the community level. And that kind of leads to some of the things we're going to talk about here. We're seeing patterns, but what do they really mean, and why is it happening? So let's talk a little bit about our limitations with the quantitative data we've seen, and also how we can dig deeper. And that's really bringing home that message of, like, we have to be data explorers. We have to continue exploring. I had a professor back many years ago, I will not say how many, during my master's program, who said, as data people, we fumble and find. And I have always respected that. We're not always going to have all the answers at first, but we keep digging. And so it's important for us to keep digging. And that involves using both quantitative and qualitative data. So let's explore some possibilities here. We know we are seeing substantial increases in meth use and mortality in our region. We're also seeing that at the national level. We have some clues about why we are seeing these increases. We also heard in your groups about what you are seeing locally and some areas of concern, the homelessness factor, incarceration, generational use, lack of treatment, and then some of those access issues, right, in some of those rural regions. And so we've really got to take a look at what we're observing and try to figure out how we can explain that. So up to now, we've also talked about those major trafficking corridors that we do have a lot of quantitative data on, but we are also a very rural region, and we have the largest number of tribes in our region. We have some unique history in our region. We can examine treatment and overdose data to get clues into why these are happening, and we have to do more exploring. So we'll just touch on some things here, but in part two, we will actually go into a lot more depth about how we can look at context with the lovely Katie Shakoyan. So we look forward to that. So just as an example, and I'm going to go over this fairly quickly, but it's a good example of how we can dig deeper. So this is a case of context, and they did actually use a lot of quantitative data here. So this is a way you can also use quantitative data to dig deeper and look at context. So let's go back to addressing a clue using some treatment data that explores rural impact. And this was a study done by Corthuis. It's at all. I won't go into all the names because I think there's like 15 names on authorship. You can find the full citation in our references section at the end of our presentation. So in this study, 79% of people using drugs reported past 30-day methamphetamine use. And this was done exploring rural areas in 10 states. So they looked at non-fatal overdose, and that was greatest in people using both methamphetamine and opioids. So 79% of people, again, using drugs reported past 30-day meth use in the rural areas of 10 states, which is pretty high. Non-fatal overdose was greatest among rural participants using both meth and opioids at 22%. Versus opioids alone at 14%, or methamphetamine alone at 6%. So we have a large number of people in these rural areas using meth and opioids. And I did see a comment, and I can't remember if it may have been Troy, saying that in Indiana they were seeing, you know, meth and fentanyl, meth laced with fentanyl, and some of those issues. So the sort of co-use of opioids and meth is a big factor in some of the mortality data that we see. Rural participants using both substances had the least access to treatment. Okay, so using both substances involved getting treatment the least. And then only 17% of those using meth alone had naloxone. So another important factor in this study. So this was all done with a program called the Rural Opioid Initiative, and I do encourage you all to check that out. They have a website with all of their publications and research, and they are really focused in on rural issues, especially with meth and opioid use. So that is a great resource for you to check out. I think this study really points to prevention public health response. So we really need a greater distribution of naloxone. We can respond with fentanyl testing strips to people who use meth in rural areas. But, and this is all great, we know how to do that, right? But if people aren't accessing medical care, that makes it difficult. And so we have to figure out, how do we connect with those rural folks who don't have access? There may be confidentiality concerns about seeking treatment, less access to emergency response services in those areas. So all of those factors really come into play with some of the context. So we can use some of the things we know how to do, like naloxone, fentanyl testing, but that still doesn't really get at what is driving, what are these health drivers that are driving these trends, so we can intervene earlier. You know, as preventionists, we always see like the river, and we want to move upstream, right? Where can we intervene early so we don't get here? And so that's what we can also look at with context. So, minding the gap, what is driving the issue in rural communities? As a data explorer, we need to address some of these growing concerns and look at these gaps. The quantitative data tell us a lot and provide us with some indication toward the why, but we have to know more. And that's where our qualitative data comes in. That can give us more context into the why. We can also use models that we use in prevention to get toward understanding and break down substance use issues like meth use and overdose. And qualitative methods can help contextualize our emerging data on this sort of fourth wave they talk about, and also illuminate those nuances that we see with meth and the co-use with opioids. In our rural communities, they face unique challenges due to reduced access and greater distances to behavioral health. We've talked about a lot of that. There's limited public transportation. I saw that in the chat as well. How can we address those things? There's greater experience with stigma and more concerns about privacy as well. So, all of that to say, we can go back to our broader framework that we all know how to use, that socio-ecological model that we see here, and break some of these issues down to really look at where we can intervene. So with the societal level, we can look at those economic conditions, policies. At the community level, we can look at the availability and the affordability of treatment, some of those things. Interpersonal. So what are the social norms of friends and family? Can we work on addressing some of those, and the ease of access from friends and family availability? And then at the individual level, we're up against a lot at the individual level, right? There's this attractive high. There's, also these mental and physical health issues that result from meth use. And then we also have the issue of suppressing those withdrawal symptoms. So we have a lot of areas that we can intervene, and we just have to remind ourselves as prevention professionals, we do have areas that we can make a difference. So, just wanted to point all that out. And Katie will go into this a lot more and show a lot of these qualitative research areas and things that go along at these different levels of the socio-ecological model, but that will help us address these quantitative data limitations with the structural factors, that community context and individual factors, all those things you guys have been bringing up in those breakout rooms. So it was amazing how well that fit together, all of your comments and feedback that I was seeing. I was like, oh, that's all what we're going to talk about in that socio-ecological model and the limitations. So thank you for providing us with all that participation. So we really want to make a difference. We have the ability to break down these issues and address them at different levels. We can use the SPIF, the Strategic Prevention Framework, to follow as a good practice so that we can make good database decisions to attack this issue. So now I'm going to check the time here. I'm going to let you all provide some more feedback. And if you don't get through all of these, it's okay. We'll continue to leave this Padlet up, and you can even continue to fill it out even after the webinar. But it will provide us with some interesting information for the next time. So Richard's going to post that link in the chat. Just please click on that and you can start completing some of those things. And then we will look at a few responses and then summarize our findings today. So I'll give you a few minutes to do that. All right. Can everyone see the Padlet? Great. I'm just amazed at how quickly you all filled this out too. That is just awesome. So what we're starting to see is questions you're still curious about. The recovery data, we saw that mentioned in the chat. Meth laced with fentanyl, specific numbers per state, and we can provide that as well. Best ways to do qualitative data collection without doing a full-blown research study. I love it. And Katie's going to address some of that as well.
That's my favorite question.
That is a great question. Best ways to do qualitative data collection without doing, oh, we already read that one. Intervention success rates. Yes, part 3, we will definitely cover more of that. Current stats in Montana. Montana is not one of our states, but I would be glad to provide the NISA data and Wonder data from there. Age of initial use, usage trends in 18 to 25. I would like to see recovery data. Lots of recovery data. Great. The link between meth, fentanyl, and homelessness. Data related to the American Indian population in Oklahoma. Insight on the recent rise to the why now. Is it making such a reappearance? Treatment for communities, better awareness. What important gaps do you see in available data that hinder comprehensive understandings? APNA data. I am not familiar with that acronym. If you want to put that in the chat, that would be great.
At the Arkansas Prevention Needs Assessment.
Oh, is that the Arkansas Prevention Needs Assessment?
I could be wrong, but that was my guess.
That's probably right, because I know that Oklahoma is OPNA, so. Disconnect.
Katie, APNA.
There's Derek. Thank you, Derek. Disconnect between consumption data and overdose data. There's a way more overdoses than what is being reported in consumption rates. Yes. Okay. Yeah, the consumption data and overdose data. Yeah, it's interesting looking at that and seeing the differences. Lack of disaggregation by race and gender. Gap in information. Access to treatment, small community sizes, suppressed data. Yeah, we have a lot of suppressed data, which makes it harder at the community level, right? Because a lot of that data is suppressed. Coordination between sources, no way to track intended use versus actual use. Huge gap of data from IHS. Yes, data relationships need to be strengthened, I agree. All right. What would be most helpful to understand? Having local data that is easily accessible, patterns of relapse, dangers of use, information tied to juveniles and substance abuse, more access to various types of data, characterization and diagnosis of meth overdose, the decline in overdose versus the overall decline in use, reasons for usage. Meth use is a symptom of an underlying need that is going unmet. So what can we do upstream? Very good. Yeah. And that context will be a big part of part 2. Specific data pertaining to youth, the impact of economic factors, local reports, and age ranges. Yeah, so just a lot of disaggregating the data. Yeah, there's a lot we don't know as we break this down. What will you do in your work to take action? Where can you go now to find the missing data? Great. Someone posted the NISDA data site and wonder. So we accomplished one of our objectives. That's always great to see that you know where to go. Local communities and community-based preventionists, great. Hospitals and law enforcement. Here's another good resource. Someone posted the online data query for Bureau of Narcotics and Dangerous Drugs. Thank you for that. Targeting prevention, education, and treatment strategies to triangulate data. Get more information on the stats in my community as well as in the state. I will speak with different agencies. Continue to keep updated on statistics, research, local stakeholders. Yeah. Okay, so the big reveal for Katie. What are we excited to learn in part 2? How to share this and any other meth-related information, the qualitative data to get a better picture, qualitative data to inform the gaps, better at being able to educate better and those in the community about the current trends, hearing client stories and understanding their issue, how to develop a young adult survey to determine their understanding of stimulant misuse, and different ways to combat the problem and how we can assist youth more on taking action steps, evidence-based treatments. Fantastic. You all did that very quickly, and I think that that's going to give us a lot of great information for part 2. So let me go ahead and stop share there. And we will go back to our PowerPoint. And has everyone seen my PowerPoint screen? Just nod. Yay, I did it. All right. So, just to wrap up, we've talked about a lot of data today. We couldn't cover everything, and we really encourage you to keep digging in your own community about the quantitative data you can find. But we did see some overall trends. So nationally, we're seeing an increase in use. We're also seeing an increase in use in our region, some states higher than others. Most of our states are higher than the national average for use, except Texas, with the overdose and mortality data. We're seeing similar things, but things are a little different. And we are seeing that sort of trend that starts around 2018, 2019 with larger increases in our states overall in our region. So regionally, we've looked at those county crude death rates for each state that showed we're getting more counties and parishes that are sort of being more affected by mortality rates due to meth. With gaps, we looked at the context. We talked about the different drivers that we don't have the data on here, you know, different ways of maybe overlaying homelessness with some of the mortality data. We used the socio-ecological model to show some of the ways we can use that framework to break things down, which we're going to definitely tackle more in part 2. So if you would in the chat, just name one takeaway, like your biggest takeaway from today. And we'll take a look at those as I move on, but I want to make sure that we address your biggest takeaway and see some of the things that you're appreciating here. And so I do see one, appreciate the info. Great. Yeah, just keep responding there and list your biggest takeaway. So our next sessions in the series, we're going to have part 2 and part 3. Katie is going to be leading part 2. We're very excited to have her. Katie, I don't know if you want to say just a small piece about that, and then we can move forward.
Yeah, yeah. I mean, I would say exactly where we left off here. So if you're interested in some of what showed up on that ecological module, that's what we're going to be digging into mostly. We are going to look at some of the existing qualitative data and what it reveals about context. And then we're going to be turning to sort of thinking about, is there data that would be helpful for you to have from your local community, and what are some ways to access that? Um, and the one other thing I was going to say, there was a lot in the Padlet about disaggregating data, which is definitely an excellent tool. Sometimes when we can't disaggregate the data because the populations or the groups are too small, or because we just don't have access to the quantitative piece, that's a place where qualitative data collection can really come in. So we'll be talking about all of that. And I'm really excited about how many people were into qualitative data even when we started.
Yes, that's super exciting. So oftentimes we see the quant, and so that's super exciting, and we're looking forward to that. Thanks, Katie. I just looked at a couple of the takeaways, and I think the interstate map was a huge takeaway for a lot of people, and just realizing that the increase is happening in a lot of states, and that people are concerned about it, but that, we have more to do. And just comparing also this other states to Texas, I see some of that. And then the multi-generational meth use and the need for more data for sure. And that's a huge issue too, especially at that community level. Well, now we come to the evaluation part of our day. And as a data person myself, I look forward to hearing from you about how we can do better, what you liked, those kinds of things. And if there's interesting things that you want to see in part 2, also, feel free to write that in the, open comment section of that survey. But we really value our evaluations, so please take the time to fill that out. Richard is posting that in the chat there, that link. And you can also scan that with your phone or camera for the QR code. I'll leave that up for just a little bit and look at some of the chat here. Seeing great webinar. I found some data sheets on the website. Oh, good. So people are already looking for more data. I love it. People sharing how to get local data in Oklahoma. Very good. Very good. You guys are being data explorers. I love it. All right. We'll keep filling out that evaluation. And here's my contact information, nicoled@ou.edu. Again, we are available for intensive, what we call intensive, but it's really like more of a conversation and a deeper discussion with technical assistance. And you're always able to make those requests. There's no wrong door. Feel free to email me, and we can get a time set up to talk to you and dig through your own data, which a lot of times is really more helpful, so we can get those nuances addressed for you. So feel free to reach out. We also have our website, our mailing list, and many products and resources on our website. So if you're not already on our mailing list, please join and you'll get notified about all these events. The last few slides are just our resources from today. I encourage you to check these out. We have a newsletter that addresses methamphetamine trends in Region 6 linked there. There also is a great sort of symposium that was done called Focus on Meth, be part of the conversation. And they have a lot of great resources and recordings there for you to peruse. There's the National Survey on Drug Use and Health resource, the Wonder database. And then these are our references for today. So I'm going to go back to that evaluation screen and we are available for questions. I'm going to look at the chat here. If you'd like to stay on and ask some questions, you're welcome to for a little bit. But the major part of the webinar is over. I really appreciate all of you for being here today. This is a concerning issue, and we look forward to seeing you in part 2.